Okay, a lot of things to possibly discuss. Obviously, I'm not going to do very many of them. One of the things I wanted to point out is to recognize how far we've come in understanding subgroups because of our better understanding of the pharmacokinetics of drugs. This was not always true. 40 years ago, you didn't know how a drug was metabolized. We didn't have good evidence of how it was renally excreted, hepatically modified. We didn't understand about the enzymes that were responsible for it. And one of my favorite old examples is how we used to dose the tricyclics. We discovered this when we approved Prozac. The tricyclics have to be given, dizipramine, something like that, have to be given at a dose of 150 to 300 milligrams to work. But people didn't start on that dose. They started on 30. And the reason was a 2D6 poor metabolizer had about 5 times the blood level of someone else. And if you just gave them the 300 milligrams, you could kill them because those drugs are toxic at high doses. So that was the standard dose for dizipramine. You started at 30, and if that worked okay, you went up. Well, we don't have that problem anymore. We know most of the metabolizing enzymes, so we know how to adjust for people, and we get blood levels on almost every patient, so we can detect unknowable reasons for some people to have higher blood levels than others. And that's not a trivial matter. It's really changed things considerably. So, but now we're looking for other kinds of differences in how you metabolize the drug by yourself, or differences in your own susceptibility, genomic differences, and that's sort of the area we're much more heavily looking at. So when we get a drug application, we look at all of the possible things that we think might have an impact on either safety or effectiveness. That could be demographic differences. It could be genomic things if we know about them. And we get blood levels in everybody, as I said. And one of the things we certainly look at is the severity of the disease, because at least sometimes the responses differ by severity, and sometimes the side effects differ by those things. We do this very well for outcome studies. Everybody, I'm sure, knows when you read the results of an outcome study, there's always a forest plot. The forest plot shows the effects, usually just the effects, not safety usually, in a wide variety of subgroups, 40 or 50 by age, gender, it would include severity, it includes all those things. We don't put those things in labeling as much as I would like to, and we're working on it. And we almost never include a safety forest plot, but there's one exception. Bleeding on apixaban is in the label as a forest plot. So you can see whether older people or women or whoever it is bleed more, and that's very useful. Obviously, you already know this. You don't want to believe every one of those things. There's 40 or 50 subgroups you're looking at, and you don't necessarily believe them, but they give you a smell. And if they're large enough, they sometimes do show something. And every once in a while, those analyses of subgroups turn up something important. I'll give you 2 of my favorite examples. One of them is Bidil. That's a combination of isosorbide and hydralazine that's used for heart failure. It was studied in 2 VA studies, and the results on the whole were negative versus placebo, and much worse than an ACE inhibitor. But when they looked at the various demographic groups, it looked as though it was the white part of the population that was not responding, but the black part looked pretty good. That was true in both studies. And we eventually allowed a confirmatory study to be done entirely in a black population, and the effect size was very dramatic. So that came from looking at subgroups. Now, they had 2 VA studies that showed that. If it would have just been one, I'm not sure we would have believed it. My other favorite example is ticagrelor. This is an alternative to clopidogrel, an antiplatelet drug. Was used in people who'd had a heart attack in what might have been the Plato study, but I didn't go look it up. What we found was that the drug worked dramatically better than clopidogrel everywhere except in the United States, where it was considerably and statistically significantly worse. So what did that mean? Why would that happen? Well, when we examined the data, it turned out it was entirely attributable to the dose of aspirin that was used more commonly in the United States. The drug, when used with 300 milligrams of aspirin, was worse than clopidogrel. The drug, when used at a lower dose, 100 milligrams or so, was markedly better. We studied the heck out of that. There was a lot of suspicion among our biostatisticians that this was, fishing for subgroups. But the same result was found in Europe, where the use of high doses of aspirin was rare, as it was in the United States, where it was more common. So it was true for both of those, and it was also true for both components of the endpoint, heart attacks and death. So eventually it got labeled with don't use with high doses of aspirin. But it arose because we looked at the subgroups and then took a good smell at them. And that's the very important thing. When you see a forest plot with 50 subgroups, you just don't believe everything you say. You go looking at it, see if it's plausible, look at it country by country, or do a lot of things and see if it's consistent. But it's very critical to do it. And I would say as a group, we're very committed to doing that. We do it better for outcome studies than we do for symptomatic studies. But my belief is that should change. We should start doing forest plots for antidepressants. Maybe there's a subgroup that works better, and then you can go look it up. So we're very interested in all that stuff, and I think that's all I wanted to say.